My patient disliked the cabbage totally. He and his family, because they have a lot of mortality post-cabbage. And he's a case of 50 years old, not diabetic, but hypertensive. He went even outside seeking for intervention. And someone put a stent in the proximal LID, and he get relieved for a few months and returned back with the same pain. This is his angio. As you see, the left main stem is diseased. There is subtotal occlusion of the proximal stent, and the ramus is ostially also with critical lesion and diseased circumflex, and the RCA is diseased distally. This patient presented after the cabbage with non-STEMI. I told him, you will get better with the cabbage. And he told me, I don't think so. But we convinced him finally to go for cabbage, and he presented after a few months of the cabbage with non-STEMI and dynamic ECG changes with high level of troponin, and this was his angio. This will simplify the cabbage. The cabbage was LIMA to the LID, and the LIMA taken as a conduit and attached to the LIMA, and then anastomose to the ramus and the RCA. And this is his angio when he presented with non-STEMI. The same finding, and this is his LIMA. The LIMA is near totally occluded after the anastomosis of the LIMA. So what can we do for this patient with acute coronary syndrome post-cabbage? Ideally, the guideline you have to go for the native vessel, but the native vessel is not simple. You have to go for left main stem stenting, IVAS guided, and we are at the midnight. So what if we try with this lesion? Can we revascularize it? Although the intervention in the LIMA is not advised. Let us try. So this is a very soft wire and pass very easily into the LIMA. And this is after wiring of the LIMA. So why don't we stent the LIMA? Let us try. If we fail, we will go to the native. We have an option. So this is, we went with the direct stenting, try to avoid the site of anastomosis of the LIMA so as not to affect the conduit. And this is the result. Are you satisfied now with this angio? If you are not, I am satisfied. The EKG changes disappear, the patient get relief from the chest pain. And we revascularized him, and the flow is TIM3, although in this LID which look diseased in all its segment. The question is not that. This patient was compliant with all his medications for the last 3 months. It presented again with the same presentation of STT changes, troponin positive, and chest pain. So what do you think the cause of the next presentation? Yes. Anyone think about restenosis? Stent thrombosis? Maybe your stent is not optimized. But this is the finding. The stent is completely patent, and the LIMA is patent, and there is another lesion at the site of the anastomosis of the LIMA to the LID. So should we go to the native and leave the LIMA? Make it simple, and we will go and try again with the LIMA. So we predilate to a balloon. At that time, I was thinking about only BTCA at this site. But the lesion and the result was not so satisfactory. It is hazy and not fully dilated. So I decided to go for stenting this segment. The stent deployed, and this is the final result. I I know a lot of you criticize this way of revascularizing of the patient, but what the most important is saving the life of the patient. If anything happened to this stent, you have another choice to go for the native vessel and prepare the patient well and prepare your IVAS for IVAS guided left main stem intervention. So our take-home message, intervention on LIMA is known to be fraught with complications including spasm, no-reflow, dissection. In case of a new occlusion post-CABG, intervention on native vessel is indicated instead. Successful intervention on native circulation is likely to cause LIMA occlusion by competitive flow. But in this case, the size of the myocardium subtended by LIMA is substantial because it's supplied to vessel. And the risk to the myocardium in case of LIMA occlusion was just to exceed that of intervention on LIMA. So intervention on LIMA was considered protective to the left coronary circulation in this case. And if indicated, intervention on LIMA is feasible. And two red lines below it, provided that utmost care and meticulousness are exercised in this case. And thanks a lot.